Okay, I think we're good.
Okay, everybody's in?
Yeah, they're still trickling in, but we got we're up to 46.
Okay, well, good. We got a full agenda, so I'm going to go ahead and start. Welcome, everybody. Thanks for making the time to join us tonight. We've got a great agenda lined up, and it's full and packed. So we're going to go quickly, and I know everyone will stick to their timelines. We'll get this meeting done right on schedule. So super excited to do that. We did have to cut the patient feedback section because of time, so I will just say, as a patient this week, I had a great experience. All the systems worked well. I was treated great by everybody, so really enjoyed that. I know someone was saying, did I have a ear piercing gone wrong? But no, it was a little Mohs surgery. So thank you, everybody that continued taking good care of all of our patients. So if you go to the next slide, please. So we expanded, and welcome to the team now, the Derm Care Physicians and Surgeons group. I know many of you know this group, but they opted to join us. And if you go to the next slide, they are seven providers strong in 4 locations. So we're super excited. I know many of them are on the call and look forward to interacting with them in the coming time as they integrate with us. But they're led by Dr. Christine Hayes and Dr. Helen Rainham. They were the partners. And then working with them, Dr. Michaelon, Dr. Freitag, Dr. Kornbluth, Dr. Rosenthal, and Riva Kristenko have all joined. And we're really excited to have them join us and be in some really nice market and areas. I think many of you know them from times gone by, but it's great that they decided to partner with us and help us become that much stronger. So welcome one and all, and welcome to all the visitors who joined in tonight. I have some other good news to share with you. If you go to the next slide. So, up until this time, we've been able to get level 2 CME credit, but now through the hard work of Toby and Heather, we are able to get level 1 CME credit. So it's a joint relationship with Rhode Island Hospital, and you will get a notification in advance of the meeting if that particular meeting qualifies for CME credit, and tonight's does. It's a 0.75 credit hour. And then the key, though, is there's a very strict deadline for you to complete the monkey survey post meeting. It is this time the deadline will be, I believe it's 8:00 a.m. next Wednesday. So when you see that pop into your email, fill it out right away and you'll get the credit for it. So really excited to expand that into our repertoire. If there are any topics you'd like to hear for upcoming medical education meetings, please feel free to send a note to Heather or Dr. Obechi Gadek. And with that, I'll turn it over to Dr. Goose.
Rich, thank you. Rich, it really is a pleasure tonight to introduce Dr. Kim. I personally have heard Dr. Kim speak as a lecturer, and I think you will agree after this evening that he's a great resource to our practice and great source of information. Dr. Lim is the former Clarence Livingood Chair and Vice Chairman of the Department of Dermatology at Henry Ford Hospital. He's current Senior Vice President for Academic Affairs at the Henry Ford Health System. He received his MD cum laude from SUNY Downstate, and he completed his dermatology residency at New York University, just like Dr. Obechi Gadek. Dr. Lim has served as president of the American Academy of Dermatology, American Board of Dermatology, American Dermatological Association, American Society for Photobiology, International Union of Photobiology, and National Council on Skin Cancer Prevention. In 2019, he was elected as a board member of the International League of Dermatological Societies. He's received multiple presidential citations from the AAD, and in 2020, he was awarded an honorary membership of the AAD. He's been recognized with the Frederick Whitehouse Distinguished Career Award of the Henry Ford Medical Group, European Academy of Dermatology and Virology, International Scientific Achievement Award, International League of Dermatologic Societies Certificate of Appreciation for International Leadership, Vincent Medal from the International Union of Photobiology and Alumni Achievement Award for Distinguished Service to American Medicine College of Medicine, SUNY Downstate. Dr. Lim is an honorary member of the following international dermatological societies: Austria, France, the Philippines, China, the Baltics, Spain, and Taiwan. He's published more than 500 articles, edited 9 textbooks, and served on the editorial boards of several journals. He is an internationally recognized authority on photodermatology, and I look forward to hearing more. Thank you, Dr. Lim.
Thank you very much, Sam, for that very, very nice introduction. I wish my mother was here to hear that. But anyway, let me start with my lecture. I'm gonna try to share screen here. Hopefully this would work. All right, can you all see my slides and hear me well?
Yes.
Yes, okay, good. All right, so the topic that Sam and Toby had asked me to cover is on phototherapy, and I will try to do so in the next 35 minutes or so. So this is my disclosure slide specifically regarding to this talk that because I'm an investigator for PCORI grant to compare home phototherapy and in-office phototherapy. I have done one session as a general session speaker for RA Medical System. So when we talk about phototherapy, there are a lot of talk about phototherapy utilization is going down in the United States. And this slide actually coming from the Boston area, Elizabeth Busney is one of the authors here. You could see that actually the utilization has gone up. However, this is based on 2000 to 2015 Medicare Part B phototherapy billing codes. However, if you look at it more carefully, the part that has gone up the most is excimer laser, targeted phototherapy. Sam just told me that your unit, your center has this type of unit also, so you can see that excimer laser continued to go up. If you look at the second box there, PUVA has definitely gone down. In our medical center, we don't use PUVA as much anymore, but you can see that for narrowband UVB, with or without mineral oil, there's a slight increase, but not very much. So the greatest increase is with the excimer laser. So what I'd like to do is to cover as an overview of the various phototherapeutic modalities that we have, and then mention briefly about some of the activities that we have to be careful about during the era of pandemic. Sorry. Okay, let's start with the overview. When we talk about phototherapy, we're talking about narrowband targeted phototherapy, UVA1 phototherapy, and also a lot of time we talk about PUVA. However, PUVA, strictly speaking, is photochemotherapy because we are giving Sorlin and then subsequently expose the skin to UVA. So it's photochemotherapy. Because of the time limitation, what I'd like to do is to focus the narrowband UVB, both in office or clinic and home narrowband UVB, and targeted phototherapy, because these two are clearly the most widely used ones across the United States and, in fact matter, around the world. So let's start with office-based narrowband UVB. This is the guidelines for narrowband UVB. We all are familiar the use of narrowband UVB for psoriasis, for CTCL, and for vitiligo. These are the 3 most recent guidelines. I was fortunate to have been involved in the development of all these 3 guidelines, and they are quite widely used nowadays. So let me move on then to the indication. speaking to this very sophisticated group of dermatologists, I'm sure you all are very, very familiar with the indications. These are the major indications for narrowband UVB, ranging from psoriasis all the way down to cutaneous T-cell lymphoma. However, we also know, I think that, narrowband UVB has been used for many other indications. This is not a complete list, but these are some of the more commonly used indication, including chronic idiopathic urticaria, morphea, other conditions, including lichen planus, pityriasis rosea, PLC, lymphodermatoid papulosis, as well as generalized granuloma annulari. The point here is that none of these has been very rigorously studied as it has been done for, say, psoriasis or for CTCL, but nonetheless, we all know in practice, we all use this, and this has been in use for a long time. This is a guideline for narrowband UVB for psoriasis, MF, pruritus, and so on. You could see that generally when we start phototherapy, we start with 2 to 3 times a week. Usually, at least I tell patients to do it twice a week, not less than twice a week, because less than that, it would be very difficult to increase the dose. It would be a waste of time and effort for all of us without being able to increase the dose. I want to start with the skin type on the left there. You can see skin type 1 to 6. You can see the starting dose. This is, by the way, based on the guidelines that we published recently on the Journal of American Academy of Dermatology in 2019. You could see that starting dose is ranging from 300 all the way down to 800, depending on the skin type. In this particular guidelines, we have just increased the rate of increase for treatment up to 20% as tolerated by the patients. Clearly, this is based on your clinical judgment, based on the patient feedback. If 20% is too fast for patients, definitely you can go down to 10 to 15%. But usually, most patients would tolerate at least 10, many would tolerate 20%. Clearly, the higher the dose, the quicker that you'd be able to higher dose, and therefore, the quicker you'd be able to get the response. Notice the maximum dose here on the right, they're also depending on the skin type, ranging from 2,000 millijoules to 5,000 millijoules, with the limitation on the face being 1,000 millijoules. This part, I'll come to the vitiligo in a second. Let me see if I can, sorry. Okay, this part, by the way, on the maximum dose, this is based on expert opinion. Essentially, a group of us, when we did develop the guideline, come up with this maximum dose based on our own practice, based on our own knowledge. There is no good study to indicate that if you continue to push the dose higher, that you get the better response. So you really have to balance between how much dose you give to the patient and what type of cumulative side effect you can potentially get. That is the reason we cut it at this. In the face, we use 1,000 millijoules, primarily because we all know face, the skin is thinner there. And of course, everybody's face is more exposed to sunlight during normal activities. So this is for all the other conditions, but specifically for vitiligo, we use skin type 1. Because no matter what skin type, what constitutional skin type the patient has, the vitiliginous area is the one that you are treating, and that is the limiting factor. That's the reason we treat patients as skin type 1 for vitiligo. In terms of side effect, this is something that, obviously patients would ask. Certain other physicians, non-dermatologists would also ask, what is the risk of giving UVB? These are 2 very good studies. The first one, the first bullet there, almost 5,000 patients with psoriasis, a study that was done in Dundee, Scotland, looking at patients with psoriasis getting phototherapy. Bottom line is that there is no increase in basal cell, squamous cells, or melanoma in those patients who were followed very closely by the photobiology group in Dundee. The second one is a more recent study up to 2012, you can see, you know, almost 23,000 patients with psoriasis coming from Taiwan. Again, there was no difference in the cumulative incidence of skin cancers. So based on what we know now, the way that phototherapy is delivered, there is really no noticeable increase in risk. Clearly, the other safety factor on that is that these group of patients clearly are going to be followed by dermatologists closely. They are going to be to have complete skin examination on the regular basis, more common than the average patient. So I think there's a lot of safety margin that can be had during the phototherapy treatment. How about vitiligo? This is the other another study looking at patients with vitiligo, much smaller number, only 48 patients, but you can see second bullet there, almost 200 treatments for most patients with a long follow-up period of up to 50 months. None, again, develop skin cancer. So we can say with good confidence that the way that it is done for all types of skin condition where we give patients phototherapy, it is a relatively safe treatment modality. I'd mentioned about office phototherapy. Let me move on to home phototherapy, because one of the limitations of office phototherapy obviously is, one, you have to have a unit. Number two, patients would have to come to the office. Time and effort of the patient is very, very valuable and very important. So home phototherapy is used quite a bit also. We use it quite a bit for patients. So convenient for patients, I've mentioned to you before, but currently, again, probably you all are familiar with this. There are three general categories of home phototherapy unit. The most common one, the most familiar one to all of us probably is the stand-up UVB unit. And it is approximately 4,000 to 4,500 or so, may or may not be covered by insurance. In my hands, approximately 50% of the insurance would cover it. The other 50%, unfortunately, patient would have to purchase it themselves. Handheld narrowband is relatively inexpensive, but it is only for localized treatment, and the efficacy has not been as well studied on that one. The handheld LED unit, the last bullet there, this one is a newcomer to the market, and it is an LED unit, relatively inexpensive compared to the $4,000. It is approximately $1,000. It works quite well because, and I'll show you the unit, because it is quite localized and it is quite intense actually to that area. So these are the most common units that we are all familiar with, the stand-up narrowband unit. You can see on the left and on the right, you know, the unit would fold, so it's relatively, it doesn't take all that much space in patient's home. The more common one on the left, for example, could have 3 bulbs here, 3 bulbs here, sometimes only 2 bulbs and 2 bulbs, and then you can have 2 bulbs here and 2 bulbs here. So depending on how fancy the patients would like to have it, you can have different combinations of that, and patients obviously would stand in front of it about usually 8 inches away. I mentioned before the handheld unit. This is the comb type of structure for the scalp, and this is another one that can be used for the localized lesions. Again, has not been as well studied, unfortunately, but has been around for quite some time, and some patients do use it for various therapeutic purposes. The newcomer is the handheld LED unit. This is a relatively small unit. You know, the handle fits into your hand, and you can see the relative size as compared to the typical iPhone, for example. And it is connected to an iPhone, and it is very user-friendly device in terms of the iPhone device. But clearly, you have to have patients who is comfortable dealing with iPhone, because what happened here is that there is a centralized monitoring station that would automatically instruct the iPhone to deliver the next dose. So after the first dose, after the patients would punch in the code into the iPhone and would tell the iPhone whether, yes, I'm turning red, or no, I'm not turning red. So the iPhone automatically, through the centralized monitoring station, automatically would tell the patient to increase the dose or not to increase the dose. So the patient doesn't have to think too much about it because it is all programmed into it as long as they respond appropriately in terms of what type of skin response that she had in terms of erythema. But again, you have to have patients who is familiar and comfortable with iPhone. I have a number of the younger patients who are using this and they're quite satisfied with it. So home phototherapy limitations, I had mentioned about insurance coverage also already, and patient compliance. Having the unit at home doesn't mean the patient would use it. So I think you have to make sure you have a motivated patients. Usually I may use it as a maintenance treatment. In other words, I would usually start patients for whatever condition, start it in the office first, mainly because I want to make sure that the patient's condition would respond to phototherapy, because even psoriasis, not every single patient would respond well to phototherapy. So I want to make sure the patient would respond first. Knowing the patient had responded, then I would move on, discuss with the patient about the possibility of getting home phototherapy. So at least when they spend the money to purchase the unit, that at least the patients would have a good probability of being benefited by the phototherapy unit at home. I want to move on to targeted phototherapy, and these are the extract unit that you're all familiar with, and then the Pharos unit is on the right. Both of them have pretty much the same design. You see the handpiece up here. You see the handpiece hidden away, it's a little bit on the back there. But because of that, it is for targeted. It is for small area of psoriasis, small area of vitiligo. General rule of thumb I would use is up to 10 to 15% of body surface. Any larger is just not practical in terms of time to do that. So let's start with psoriasis. This is by now a pretty old study by Steve Feldman, but this is still probably the best study and the largest study that was done at that time. You could see the starting dose is minimal erythema dose, and physical characteristics of the lesion usually is approximately 3 MEDs, and twice weekly for 10 treatments in this particular study. You could see that in 66 of the 92 patients, there is greater than 75% clearance. But 75% of the 72% of the patient achieve greater than 75% clearance, even with only 6 treatments. So it's a very, very rapid response, because the advantage here, you can deliver pretty high doses to small area of the skin without being concerned that the rest of the skin would have UV-induced erythema. You could see in the last bullet that 50% of the patient had greater than 90% clearing in 10 or less treatment. This is one of our patients. You could see even after a single treatment, you could see that fairly significant central clearing of the patient's psoriasis. Okay, so it is a fast treatment, fairly and is very, very useful for patients with localized disease. Another area that is very helpful, obviously, is the scalp, because you can get to the scalp very easily as compared to home or to total body phototherapy. So noticeable improvement should occur by 6 to 10 treatments. Usually what I do is that once patient had good response after 15 to 20 treatments, I just stop the treatment and then move on to other types of topical treatments that the patient could be using, so without having to taper. So this is unlike total body phototherapy, where we usually would taper the treatment down. Ideal for those with less than 10% of body surface involved in residual resistant lesion following other forms of treatment is another type of lesions that would be very helpful to use targeted phototherapy. Keratotic lesions on the palms and soles is another indication for it. As mentioned already, scalp lesions, because you can part the hair and get the unit into the light source into the scalp. So it is quite helpful for patients with localized scalp lesion. Limitations: perilesional hyperpigmentation, especially for the face in patients with dark skin. For example, when you treat that, the surrounding area would tan. So you do have to forewarn the patients. You will have some tanning on the surrounding area of the skin, especially for vitiligo. You have to tell the patients that you will have not only the vitiliginous area, but also you have darkening of the skin before getting to the normal area of the skin. So that's something that you have to manage patients' expectation. Just like any type of office-based phototherapy, the travel time to the phototherapy unit, and as mentioned before, insurance coverage and the expense associated with it. Those are clearly very practical limitations for this type of phototherapy. The other part that I will cover later on is that during this pandemic, we always have to consider the safety of the operator. So at least in our unit nowadays, we do not treat patients on lesions around the nose and around the mouth, mainly because it's just very difficult, obviously, to keep that area being treated and still keeping the safety of the operators. Face, other parts of the face is no problem as long as that area, the nose and the mouth, can be covered with mask of the patients. I've mentioned the other indication that we use a lot for is for vitiligo, and this is a study to show that indeed this is another treatment that works very, very rapidly for the treatment of vitiligo. And this is one of my patients. You can see following excimer laser for after 6 treatment, you're getting quite a bit of follicular repigmentation in this patient, and after 32 treatment in this case, you can see quite a bit of repigmentation, most of them follicular repigmentation. You could see also all of you have treated vitiligo, I'm certain. You could see that this is very typical response, that the area will become darker as the color comes back. You have to assure the patient that those dark area eventually would blend with the natural skin tone that the patient would have. Again, managing patient expectation. Again, the other part that we have to manage patient expectations for, no matter what we have nowadays, we still cannot get easily 100% repigmentation of any type of lesions. So this, for example, after 32 treatment is considered to be a very good response already. So you have to educate the patients to manage the expectation on that particular aspect. I'd like to move on now. Sam asks about the phototherapy and biologics. I mentioned that I will cover this. This is a new reference that has just been published. Just came out actually in February issue of 2000 of this year from our group. And the other one in terms during the COVID pandemic, some of the recommendations that we have are published in the July issue of the American, of the JAD. So let's start with the biologics versus phototherapy. What are the advantages of phototherapy? What are the advantages of biologics? Let's start with phototherapy first. This has been around for a long time. So we do know that it is effective, that especially for targeted phototherapy, it is rapid acting, so it is clear lesions very, very rapidly. We know that it has been around for a long time, good long-term safety record. I've shown you some of the data about that. And the cost is relatively reasonable. Most of the time for psoriasis, for example, for mycosis fungoides, most of the time it is covered by insurance. How about biologics? We all use biologics. We use biologics quite a bit. And we all know what are the advantages of biologics. It is highly effective. Takes about 8 to 12 weeks for any type of biologics to be effective. We do know that also it is an immune modulators. Thus far, we do know that biologics has very, very good safety record. And obviously for the patient, it is very convenient to administer. Once we have taught them, we have teach them how to inject themselves, it is quite easy for them to do it. What are the limitations? For phototherapy, clearly you have to have available units in the office or in the clinic. Patient access is another one. Patients would have to be able to go there easily, get there 2 to 3 times a week for the treatment. For any type of unit, to have a unit in the office, obviously the equipment is there, so there is a capital outlay. Of course, you have to have a trained staff, and of course, it will take up space also in the office. I've mentioned about patients' time and effort to travel to phototherapy unit 2 to 3 times a week. And then especially for home phototherapy, the patient has to be well educated as to how to use the home phototherapy unit properly. What are the limitations of biologics? I think the most important one, obviously, is cost. We all I'm sure one of our favorite activities is to go through the prior authorization for various things. And obviously costs for biologics is one of the aspects that we all have to deal with pretty much on a daily basis to work with the insurance company to get patients approved for biologics. The other part is that there is frequently asked is that how safe is it to use for biologics during COVID-19? So I'm going to cover that last aspect because this is a relatively new questions, new information that we all have to recognize and have a good understanding about. This is one of the studies that was published from Italy in JAD, you can see in July 2020. They reviewed patients with psoriasis on biologics and renal transplant patients on immunosuppressive medications from February to April of 2020 during the first peak of the COVID-19 in Italy. Let's take a look at the result. This is taken from the article. In the general population, you could see the COVID positive rate at that time was about 1.2%. About 0.2 were hospitalized for COVID-related disease, and death from COVID is 0.08%. Let's take a look at the patients on biologics. You can see 980 patients. There is none that got hospitalized for COVID-related disease. None died from COVID-related disease. Likewise, renal transplant patients were on immunosuppressive medications. One of the 247 was hospitalized for COVID-related disease. None died from COVID-related disease. So, this shows that it is relatively safe to be used. Since then, there have been others, and this is coming from our group that was published in December issue of JAD. This is a retrospective cohort analysis within our system of the patients who had received patients with immune-mediated inflammatory diseases. They were treated with immunosuppressive medications and tested for COVID-19 between February to April of 2020. That was during the peak of the first peak of COVID-19 in Detroit. Let's take a look at the result. In terms of immune-mediated inflammatory diseases that was included in this analysis is listed down here, and then immunosuppressive medications, practically all immunosuppressive medications that we all use in our general practice, from biologics all the way to intravenous immunoglobulins. The results show that there are a total of 213 patients. Approximately 1/3 of them tested positive for COVID during this period of time. As I mentioned, that those patients were on different type of immunosuppressive therapies, and the important part is that immunosuppressive therapy was not associated with significantly greater risk for COVID infection, or also not associated with severe sequelae when controlling for other comorbidities that the patients have. Some suggestion that TNF-alpha inhibitors may decrease the odds of severe infection. Relatively small number, but there's some interesting suggestion there. So based on all the data that we have, I'm just citing two articles there. I think at this moment, we all are very comfortable to use biologics, even in the era of pandemics. Lastly, in the last few minutes, I'm just going to give you some practical tips that we have developed, that we have used in running phototherapy unit. This is essentially a consensus opinion of the member of the dermatology expert committee of the PCORI study. This PCORI study is the one that I mentioned before, comparing phototherapy in office versus phototherapy at home. The PI is Joe Gelfand from Penn. You could see the four of us there: Joe Gelfand, Steve Feldman, Abby Van Voorhees, and myself. And we look at essentially we put our collective experience together. And these are the information that we published. General principles is that obviously we need to follow local public health recommendations in providing phototherapy services for the patient, to consult, for those of us who are medical center based, obviously to consult with the hospital infection control to make sure we comply with their rules and regulations. And as physician, we need to balance the risks and the benefits for patients and to optimize safety for the staff. Both of them are very, very important. So the general principle is consider other options. I've mentioned to you about phototherapy at home already. And also, if during the sunny months, at least consider just judicious exposure to sunlight in place of coming to the office 2 to 3 times per week. Recommendation for the patients, these I'm sure all of us are practicing this already. Screen for symptoms, attend session alone. For minor, 1 guardian is allowed, obviously wear mask, except during the total body phototherapy service. For patients, hand sanitizer, individualized goggles, again, very, very common practice. I'm sure we all do this. And importantly, I've mentioned that we need to make sure that our staff is safe. So in order to do that, what we have done and what we have recommended is to schedule patient in the beginning, not more than every 30 minutes, until the staff would get used to the flow and the extra cleaning that they have to do. Then once they're comfortable, if they're comfortable, then they can increase the patient. Right now, we do it every 20 minutes. Waiting area, this is, I'm sure we all do this, to arrange the seating to be 6 feet apart, wear mask and apply hand sanitizer. Again, these are 2 very practical part that I think we need to make sure in terms of the fan. We all know that phototherapy unit can generate heat, and sometimes staff would turn on the fan to cool the unit down so that the patient would feel more comfortable. We strongly recommend not turning on the fan to minimize the recirculating of the air in a closed unit. If need be, if the patient is too hot, the treatment can be fractionated to avoid excessive heat buildup. We are not talking about UVA1 unit, but UVA1 unit generates a lot of heat. And so usually now we have a UVA1 unit in that Ford. We treat the patients at the end of the day because you do have to turn on the unit, the fan for this particular treatment. So we treat 1 patient at the end of the day. Lastly, the patient high-touch services would have to be disinfected, so staff would have to do the extra work to clean those areas. High-touch surfaces, we don't clean the lamp because there are grates in front of the lamp, so we don't have to touch that. But the handles, the handlebars, and so on and so forth, we clean in between patients. That's the reason that the flow is going to be a bit slower during this pandemic time. I've mentioned already about targeted phototherapy. For safety of the staff, treatment of the facial lesion, especially the perioral area, should be minimized. And usually, actually, in our practice, we don't treat those areas, but we are now treating the area of the eyelids, for example, or the foreheads. For patients with vitiligo, for example, we do treat those areas, just that not around the perioral area. Many of us would get asked, how about UV? Can UV kill the virus? Would it serve as to sterilize the unit that way? What I want to emphasize, and then we have done a lot of work on this during the pandemic, is that UVC for sure is virucidal at 1 joule per centimeter square. In fact, we have published on this that to show that SARS-CoV-2, coronavirus 2, is killed by the 1 joule per centimeter square of UVC. So it does kill UVC. UVC kills virus, including the SARS-CoV-2, but the dose has to be a good dose, which is 1 joule per centimeter square. Now, as we know, we don't use UVC for phototherapy. We use UVB for phototherapy. This is the efficacy of the dose, the wavelength, and the dose that is needed to kill the virus, to inactivate the virus. You can see for the UVB, it is very, very high. It is not practical. In other words, as you turn on the phototherapy unit, it really is not sufficient to kill or to inactivate the virus. So, we still have to do the steps that I have just mentioned to you before. So what I have done is that I've covered give you an overview of narrowband targeted phototherapy. UVA1, I just mentioned very, very briefly in terms of the fan, but the first 2 are clearly the ones that we use the most common. And I give you some of the more practical tips as to how to run a phototherapy unit during the pandemic. As we look at the city of Detroit here, I would like to thank Sam and Toby and the rest of the group for inviting me to participate. Hopefully this has been useful for you as you continue to reopen your phototherapy unit. Thank you very much.
Yeah, thank you very much, Dr. Lim. it may be, it may be nice if we might have a few questions from the participants for Dr. Lim. They could entertain it at this time. I have one, Dr. Lim.
Sure.
Maybe could you comment on narrowband UVB in shielding of the eyes and the genitals?
Very, very good question and very practical question. Let me start with the genital area. Routinely, we do shield the genital of men. We ask them to wear jockstrap, or they can use a face towel to put in that area to cover that. Mainly because of there's some data, primarily from Rob Stern, who used to practice not too far from you guys, when he was looking at PUVA. That PUVA, in his cohort of patients that he followed for many, many years, there is a slight increase in genital carcinoma. Should be noted that many centers, including the European, did not find that particular effect, but still, to be on the cautious side, we do it on a regular basis. The eyelids is another very, very important and very practical questions. Routinely, for patients with psoriasis, if they have no involvement on the eyes, we shield the eyes. But realistically, it is not very, very important, because what happened is that it has been shown for many, many years ago that eyelid, the UV does not penetrate through the eyelids. So it is completely safe to treat. In fact, we have a lot of patients with vitiligo. Clearly, we all know patients with vitiligo, they have many of them, they have lesions on the periorbital area. To cover the eyes for those patients, it is then they would not get the benefit of the treatment. So usually what we do, including in kids, if they can follow instruction, we ask them to close the eyes, and then we treat the eyelids we treat the face without any use of any goggles. Clearly, with children, you have to make sure they're mature enough that can follow the instruction well.
We have a question from the audience. It was in reference to the role of narrowband UVB for atopic dermatitis, and is it covered by insurance?
The second question is generally it is covered by insurance. Atopic dermatitis is not as satisfying to treat using narrowband, mainly because they don't respond as dramatically as psoriasis would. We can control the condition, we can bring down the activity quite a bit, but clearly we all know, it is almost impossible to get to completely cure them with UVB alone. So even though we still use it, but we don't use it as commonly, especially now there are other treatments. Dupilumab is the one that we use a lot, which is significantly better. But we do use it for those patients for whatever reasons would prefer UVB treatment. Beneficial, but not dramatically so.
It looks like we also have a question from Dr. Jenkins. I've just unmuted your line.
You have to unmute your computer. Dr. Jenkins, you're muted.
In the interim, if you don't mind, while we're figuring that out, I was just going to ask what you think about the efficacy of narrowband for elderly patients with unknown pruritus of unknown causes.
We do. Very good question. We do use it routinely and regularly. It is probably 50 to 60% of the patient would respond to that. Clearly, for elderly patients, the other challenge is that many of them is not so easy for them to come to a unit 2 to 3 times a week. So that is another limitations. But definitely for those who could come, it is helpful for some. There's some data to show that that narrowband probably is not as effective as broadband UVB, but realistically, broadband is practically no longer existence in most units. We have one primarily for photo testing, but we don't have a broadband UVB unit. So it's going to be very, very hard to do a rigorous study to compare the two on that. Same thing with renal pruritus. For example, renal pruritus, the studies was done by Barbara Gilchrist, and that time was using obviously broadband UVB. So, we could transfer that, for those patients with renal pruritus, you still use narrowband, but it's impossible to do rigorous comparison between broadband and narrowband anymore.
Thank you so much.
If we have a little bit of time, Dr. Lim, I have a little pivot question for you.
Yeah.
I was wondering if we could get your take on the recent New England Journal of Medicine article about the potential overdiagnosis of early melanomas, and what do you think of that, and given your experience?
Yeah, it is. As you know, it generated a lot of discussion, a lot of controversies on that. And I think it is a challenging one, because if one say that one should not be doing annual skin examination, it is, I think, doing the American public a disservice. Recently there is the guideline that is being proposed by U.S. Public Health Services Task Force to asking all of us, actually, and AED has responded to that. Also, is it necessary to do annual skin exam? This task force, every 2 years or so, they ask the same question. And the challenge here is that I think we all know that, especially for fair-skinned individuals, there is a very significant benefits of doing annual skin examination, including for melanoma. And then, however, on the other hand, we also know for dark-skinned individuals, melanoma occurs in areas that is not always sun exposed, on the palms and soles, sometimes on the mucosal surface, and those actually has nothing to do with sun exposure. And do we need to, again, even for those patients, for us to say, well, it is no benefit to do annual skin examination, to me is a bit difficult to justify. So I feel that annual skin examination is still helpful. The question is that whether we are overdiagnosing melanoma. Again, that part is another kind of worm, because they cited there's an increase in on the diagnosis, but could we be because we biopsying them early, and because of that, the diagnosis is made, and because of that, the mortality has not gone up. So there's a lot of issues that needs to be addressed in that.
Thank you very much.
Thank you.
Any final questions for Dr. Lim? All right. Well, thank you again for joining us. Very informative.
Thank you very much for having me.
Yeah, great. Well,
Okay.
Have a great evening.
Take care. Bye now.
Thank you so much,
Bye-bye.
Dr. Lim.
Thank you.
Okay, I think up next, Meg.
Yes, good evening, everyone. Just wanted to go over our new workflows that Dr. Becky Gadek and Kelsey Peterson and I have been working on. We just wanted to make sure that the providers had an updated workflow that they could follow, and that we had everything included in the actual order form that everyone is using. So some of the items that we did add on to the new form were mineral oil preference, frequency of visits, and as Dr. Lim had actually just was talking about, the body parts to be treated and the body parts to be covered. This form will continue to be scanned into both Centricity and EMA, and all of these forms can be found in the Resource Center. Next slide. The consent form we did quite a bit more work on. We did add the benefits of UVB phototherapy, and then did a little bit more research on the risks and side effects too. So we wanted to include that. Our new consent forms are also following Medicare guidelines. So as we move forward doing all these new consent forms, you will notice that they'll be a little bit more extensive. Next. Also, the patient instructions, we felt that there wasn't really enough information for patients. So we did do a little bit more work on this also, just really going over the before treatment, protective equipment, post-treatment, and important notes on if a patient was burning. We wanted to make sure that staff were aware that that could be a side effect. The best results are 2 to 3 days a week, so that the patient is there on a consistent basis, and to notify the medical assistant of any new medications that might impact that, and always to follow up with the provider if they have any questions. Bree did a really great job. She's updated our ancillary services by location. As you see, most of our services are currently open. We do have a new phototherapy booth that actually is in the Watertown site now that won't be available until the 1st. And then some of the New Hampshire sites are still delayed. We are continuing to retrain staff that weren't really doing phototherapy over the last few months, and also to train new staff that we have more cross-training for staff too. This chart will show you which days, what site, and the availability of time. But after Dr. Lim's conversation, we probably should look into making sure that we're doing it every 30 minutes to account for the good cleaning of the rooms. When the patients, so I think one of the biggest workflow changes for the providers now is the MA's workflow has changed so that they are to document per Medicare guidelines who the provider was that was on site the day that they did the treatment, if it is not the ordering provider. And previously, the note was actually sent to the provider on site. We have changed that to go back to the ordering provider. So those are pretty much the main changes that we have put forth. And like I said, everything is found on the SharePoint or Resource Center. So readily available for your view. It's all under the Policy and Procedure tab. And if you have any questions, feel free to email me at any time.
Great, thanks. Appreciate that. Dr. Becky Godek.
All right, so I know I'm personally much more comfortable ordering phototherapy now that I know that there are guidelines. The MAs have been trained, and it's actually been interesting. In the last couple of weeks, I've been seeing some of the treatments and the diagnoses for some of the patients that I've started on narrowband, and I've had to change a few things, increase the frequency of. So I actually quite like the fact that the notes are going back to me. So thanks, Meg, for making all those changes. All right, so switching now to MIPS 2020.
Hey, Toby, real quick, we have a question from Dr. Rosenbaum, I think, on that topic.
Okay.
Dr. Rosenbaum.
Hi, can you guys hear me okay?
Yep.
Yeah, good. So I don't have the protocol sheet in front of me, but I'm doing this from memory. So when I do phototherapy, I actually do it myself. I don't have a technician. I actually adjust the machine for each visit. And in general, I follow Dr. Lim's suggestion of, in general, upping the dose by around 20% per visit if the patient is tolerating things okay. As I recall, when I looked at your protocol sheet, you don't increase by percentage. You're increasing, as I recall, by something like 40 millijoules per visit, which is fine in the very, very beginning. But if I read that correctly, when they're up to 1,000, 1,500 millijoules, rather than bumping them up, 200 or 300 per visit, which you could do by the percentage, you're only bumping them up still, 40 millijoules, which I think is really not a reasonable or efficient way to do things. I mean, you may certainly have less, potential, burning or uncomfortable patient issues, but the amount of improvement you're going to get going up that gradually is, I think, less than optimal.
Dr. Rosenbaum, I think you raise a very good point. And I was noticing that as well during the presentation. And I know those original guidelines that were put forth, I think partly out of safety were put that way, but also were based on guidelines that have been published from phototherapy textbooks. And so were based on what was felt to be appropriate. I think it's worth bringing the guidelines that were just published by Dr. Lim at the AAD to the Physician Advisory Council to see how we might want to modify what our treatment guidelines will be. So thank you for bringing that up.
Thank you.
Yeah, I agree. What I've been doing is just manually changing it. So if I have a patient that's already at 1,000 millijoules, I just tell the MA how much to increase by. But that's a great point. All right, so we're switching topics to MIPS 2021 planning. I know this has been long in the making. So one great news is that Bernadette Silprizio has been a new addition to our team. So she's the compliance and clinical strategy coordinator. So she's going to be helping us with the centralized MIPS planning efforts. So you will be hearing from her shortly. She's currently training on MIPS. She's not currently at this meeting. Next slide. So I sent the agenda and the slides to everyone beforehand, just so you can take a look at it, because we don't have much time right now, but I want to make sure everyone fully understands what we have to do, because this is timely and this is critical. So we're going to be starting with the MIPS overview. We'll talk about the 4 components of MIPS: quality metrics, promoting interoperability, improvement activities, cost, and then the tracking and reporting that we're going to do. Next slide. So why do we care about MIPS 2021? Well, if you're not part of an alternative payment model and you see a minimum number of Medicare patients, you have to report MIPS, and it's becoming more and more important. So there's a possibility to obtain up to a 9% surplus or penalty. So that's important if we don't do this right. And each year, MIPS has actually been going up. It's just been kind of creeping up. And every year something has come up. So it hasn't been as pungent, I guess, to our fee schedules, but there's a potential that this can actually, this will affect our 2023 Medicare fee schedule, provided everything else goes well this year and COVID isn't an issue anymore. So I talked about the 4 components of MIPS. So quality is the one we always focus on, but there are actually a number of other categories that are important. So the promoting interoperability, improvement activities, cost is automatic. So all that they care about is how much you cost to Medicare compared to your peers. So that's automatically collected. So we won't spend too much time on that. Next slide. So some of the changes to happen are that because of the penalty, we need to monitor this closely to make sure that we are not penalized. At least we are breaking even. Emma is actually going to help us streamline this and was actually selected for the capabilities for MIPS that other EMRs do not have. We are currently working to train the medical assistants because they're going to be helping us collect a substantial number of our MIPS metrics, but they actually can't collect everything because the clinicians really do have to. And we've worked with the PAC to select the least burdensome metrics that we can all select from. Next slide. So quality is the one that we usually focus on. And just so to simplify it, everybody's going to report on 6 metrics. And you can report on, there are hundreds of them that you can select from, but we've narrowed them down to 13 of them that are right here. We're going to collect the 13, and then we're going to see the 6 ones that we have the highest of. The reason why we don't want to just only collect 6 for the entire year is because there could be lapses in collection, and because of that, we may not get as high scores as we want. So we want to maximize the amount of points that we can get, and we're going to aim to report as a group so that we all bring each other up. There are a number of metrics that are collected by the clinicians, about half of them, and then about half of them are collected by the MAs. Unfortunately, it's going to be really difficult for the MAs to collect the ones that are clinicians, because it requires some knowledge what's going on clinically. Next slide. They're supposed to be reflecting something about the outcome of what we do in dermatology. Some of them are general, and these are the ones that are collected by the MAs, like advanced care planning. And a lot of you, especially those folks at DPI, already see the MAs collecting them through the MIPS impression and plan. And also in the clipboard. Next slide. And this is for the MIPS impression and plan for those of you who haven't seen it. Most of you should have seen it by now, and the clipboard from the desktop. Next slide. So what are you going to be collecting? So we would like to start with having all the clinicians start collecting follow-up, melanoma, tuberculosis screening, psoriasis, to have the patient on a biologic, so psoriasis clinical response, melanoma reporting, and melanoma coordination. Each of these can be reported through EMA in a specific way. So for example, the biopsy follow-up really says, if you have a new patient coming in for a biopsy, have you communicated with the patient about their biopsy result in a timely manner within 14 days? So with the MIPS impression and plan, you can definitely, and you all, I'm sure have seen, or a lot of you have seen it. If you haven't seen it, please let me know. It's pretty easy, and I'll show you how to do it. You can also do something that's a manual override, and I also have some snapshots of how you can do that. But there will be more training and more of an in-service later on. But I just want to put it in your mind that really the quality metrics really have to start being collected from January 1st, 2021. So it's the tickers are already kind of going, but it's because there's so much going on that we didn't really launch this until now. Important to start collecting these quality metrics. Melanoma have a system in place already to tell melanoma patients when to come for their next appointment. As long as you have that system in place, when you're selecting the history of melanoma impression in EMA, there actually is an automatic quality metric 137 that you can just pull up, and you can also just select that, or you can use the MIPS impression and plan. Same with tuberculosis screening. You have a patient on a biologic, you can easily just do this. Same with psoriasis clinical response. As long as you're documenting, so if you're in the psoriasis impression, as long as you're documenting the BSA of 0 or 1%, or the PGA. So if you're on the desktop, it's I'm happy to show everybody where it is, but it's right around where morphology would be. As long as you're documenting that, and then putting it in the MIPS impression and plan that you're seeing that your patients who've been on biologics have improved, then it counts. Melanoma reporting is really more for the pathologists who are using EMA. So when they're reporting CPT 88305, they also just confirm that they've reported the other items in the quality metrics. And then melanoma coordination. This is one probably that we're not going to be using too much. And one thing I want to stress is we're all going to be mix and matching, right? So it's not like every single one of your patients, you're going to be documenting a biopsy follow-up or a melanoma recall. You only document it on the patients where it matters, right? So melanoma, if they have a history of melanoma or current melanoma, psoriasis or tuberculosis screening, if they're on a biologic, biopsy follow-up if they do a biopsy. Next slide. So here's what the MIPS impression and plan. You are in your impression, you literally type MIPS. You can just kind of practice this. You type MIPS. After you type MIPS in the impression, you go to plan, you go to MIPS quality, and then this little pop-up comes up, and it has a lot of the relevant metrics that you could potentially document. You see one for melanoma that I highlighted, biopsy, biologics. So it's pretty easy. And then you see that there's a drop-down menu that you just select whatever you need. Next slide. If you do this, it's really automatic, and it really helps us improve our metrics. And remember, if we're going to report as a group, it's really important for everybody to make sure that they contribute so that our scores don't get dinged, unfortunately, if we don't have a good quality score. For MIPS, you can actually track yourself. So if you're on the home page of EMA, you can go to MIPS overview, select your name, click on the quality button. Next slide. You can click on the metric that you want to expand. So Bernadette has already gone through a lot of your MIPS quality metrics and selected them. So you're going to see some of them already popped up. You're going to select them to see how you're doing. If you believe that for some reason you actually hit the quality metric for that patient, but EMA for that particular visit is saying that that patient is unfavorable because you didn't select it. And as you can see, I am delinquent for these 4 biopsy follow-up patients. you can manually override it and say that you are favorable, and then MR just kind of reads that in. Just make sure that you do have documentation showing that you're favorable. Next slide. This is a lot, I know. That's why I sent the slides along for folks to review on their own. And if you have any questions, just let me know. But this slide was just to let you know what you could potentially report on. So all clinicians will have the MAs be reporting the far left metrics. So the advanced care plan, the flu vaccine, pneumonia vaccine, tobacco, high-risk meds, documentation of current meds. But then if you're a general derm clinician, you can think of 5 more that you can potentially report on. If you're a pediatric dermatologist, you can think of others that you can report on. Same with Mohs, same with pathology. Next slide. So promoting interoperability, I won't spend too much time on it, just to say that one of the most important things that we have to do is actually open up the patient portal in EMA. And this is going to be rolled out very soon by Kip, our consultant, and the operations team. One major thing is that for the EMA portal, patients will have access to your notes. So patients will be able to read your notes. So digest that, but it's going to be important for patients to have access to that for us to actually get credit for promoting interoperability. Next slide. Improvement activities, you don't have to worry about that, because the fact that we have 24/7 call, and thank you for all your patience with all the call schedule changes, that basically helps us qualify. So there are things that we have to do on the back end, but that helps us qualify. Next slide. So what's going to happen now? Well, so we're going to have to train the medical assistant staff on the quality metrics, make sure that they're all collecting all the 6 that I had mentioned. We're going to be reviewing the MIPS scores for all of you, and then sending notes to you if we see, you actually have an unfavorable MIPS rating for your biopsy follow-ups because you haven't been doing them. We'll retrain when we're not achieving that goal, and eventually we'll report MIPS in Q1 2022. So this is going to be a year-long process. Next slide. And this just kind of reflects that. And I know this was quick, but if you have any questions, feel free to email me. Many of you know, though, that apparently I've been told that I'm already at term for my pregnancy. So I will be out for a while, for about 2 months. But I'll probably be checking email. And you can also email Bernadette as well. All right. So the next one is also mine. So clinical innovation and quality at AP Derm. So I'm very excited about this, and John and I are going to be speaking about this. And let's see, there's a question from Dr. Goose. Oh, so Dr. Goose mentioned that we might want to mention who's excluded from MIPS measures. So essentially, if you're a part of an APML, part of an alternative payment model, sorry. Some folks affiliated with MCIPA are also part of that. Some folks affiliated with partners in other ways are also part of that. But in general, if you're using EMA, most likely, it's not because you're using EMA, but just because of the practice affiliation that you have, most likely you're going to need to report MIPS metrics. And someone, so Diana just asked the question, if a medical assistant brings MIPS forward from the previous note, will EMA register this? Yes, it does. The only issue is that you have to make sure that whatever documentation that you need to bring the MIPS forward is there, because in the rare case that we are audited, we need to prove that we actually did ask those questions about flu vaccine or something else that the medical assistant did bring. On the clinical innovation, I'm excited about this because this is why I joined AP Derm. I was sold about the idea about creating a practice in the New England area that really had pride about the quality that it could provide to the patients. So this would be somewhat of an academic practice with the agency of a private practice. Next. So what we're year in 2021 is that we're really aligning our goals with the major goals of the company as well. So what are we going to do? Our goal is eventually to support, attract, and retain the best clinicians, patients, and teammates. And we really want to set ourselves apart as the pioneer and leader of quality. We're going to talk about clinical research and technology innovation projects, centers of excellence projects, improving the clinical workflows. And I already spoke about MIPS collection, but that's also part of it. Next slide. So starting with APDerm as a pioneer and leader. So what we want to do is all the programs that we're putting together, really, even academic practices don't really have this. You know, a lot of quality conversations are focused only on MIPS, right? And that's kind of the primary thing. But we all know that that's a burden. And we all know that we're not measured by how many patients that we see get the flu vaccine. Like that doesn't really tell us if we're a good dermatologist. So what really tells us if we're a good dermatologist? You know, a good dermatologist when you see one, right? So, and it's almost a circular answer, but it's true. So what we want to do is really create our own metrics based on how we think care should be delivered, and we're calling those quality performance indicators. And we're going to use that to demonstrate our value to the payers to be able to obtain superior partnerships and better rates. Next slide. So we've already started showcasing how our approach is both externally and internally. There was actually a publication that just came out for those of you who get practical dermatology in your home called Reclaiming Quality in Dermatology, and I will be sending that link out tomorrow. So that explains what our program is, how we think about quality. And we want to show that to the rest of our peers, that we really want to set ourselves apart. Last year, we even published in the Dermatologist as well about how APDerm tries to really make sure that patient access is very important and actually showcases the high quality of care that we can give, because if patients can't get in to be seen for an urgent issue, then they're going to go to someone who may not know as much about dermatology, and that's actually part of quality as well. So there's more to come on this. We're really going to be pushing our quality thought process forward, and I will be sharing a lot more later on. Next slide. So we are also looking at quality performance indicators, which I think I shared last year actually at a medical education meeting, and really delving into some numbers that, working with the PAC and other folks, we've chosen as metrics that we should be looking at. So things like outliers. So not necessarily just looking at the pure number of benign to malignant biopsy ratio, but outliers. Looking at clinical improvement for inflammatory dermatoses to show that we do see improvement. A lot of our patients are very happy about that. Most appropriate use criteria, pathologist concordance with diagnoses. We're looking at outliers in biopsy utilization, showing that, you know, yes, over biopsying is bad, but under biopsying can also be harmful for our patients. Same with most stages. We're looking at the utilization of our generic medications and adherence to our biologic formularies. Time to care is so important, because if our patients can't see us, then they're either doing to them or going to a place that may actually result in higher cost of care, diagnoses or under diagnoses. Patient satisfaction, as you all know, is really important to us. Next slide. So our clinical research and technology innovation program is also very important. Next slide. And you all have kind of heard me speak about teledermatology, the fact that we were able to launch it, and many of us are continuing to see telederm patients, and we hope to actually make this a permanent part of our practice. Next slide. John will now be speaking about about APDerm as a research and innovation leader.
Thank you very much, Toby. Hopefully everybody can hear me okay. Yeah, I like Toby. I just want to say that I was really attracted to DPI initially because of the collegiality and the development of an almost an academic like feeling in a private practice setting. And that has sort of just been borne out even more through the merger and working with APDerm and everybody else. And I'm excited to see how the network's growing. One of the things that I like to think of when you look forward to how are you going to change your practice, how are you going to bring new innovations to patients, you know, one of the biggest ones is that there's a lot of ways to do that. some people focus on research, some people focus on just seeing the most patients they can to increase access. We're all involved in this CME and the building on this foundation, but it really is sort of a team sport. Can we advance a little bit, please, Heather? This is a little aside I put here. Every time I read about a new drug in one of our publications, I have this note in my iPhone, and this is just a partial, and there's no specific emphasis here, but this is just a bombardment over the last few months of things I've read about, and it's not just in derm, it's also in new things in rheumatology. I mean, these are kind of impossible things to take care of just on your own in a timely fashion. Eventually, you might get there, but a lot of these things are going to benefit our patients today, and we need to learn about them. We need to move forward with them. So like I said, it's a team effort to confront these challenges. And one of the things I'm excited to bring to us with hopefully starting research a little more broadly is to offer things to patients that have either failed all of our current therapies or just completely new things like the JAK inhibitors that can really bring a new change to certain diseases that have been very difficult to treat in the past, like extensive alopecia areata or bad atopic dermatitis. Go forward, please. And so that's one thing that we're going to try and do with this research and innovation infrastructure, and hopefully encourage people that are interested in getting their name out there or publishing new findings or case reports. I'd like to create a pathway and a support infrastructure to make this a little more tenable for people who are very busy clinicians and have other demands on your life. The more we can support this, the better AP Derm can do as a whole. Next slide, please. And when it comes to innovation, I think there's several different ways to think about innovation, but one of the ways I think about it is like, what's going to be the next dermatoscope? There's been a lot of things along the way. If you click forward, I think I put something on here about Melifind, which I don't remember if anybody else remembers Melifind, but it kind of went to the dustbin of history. It was not a great technology. It was a good technology, but it just never really got adapted well. And a lot of people just wound up not using it, and the company folded several years ago. So, not all innovations that we come out with are actually going to be quality improvements. And a lot of these things go back and forth together. Advance it, please. But the thing I like about dermoscopy, and the reason I sort of chose this as a thinking about what's going to be the next thing is, if you look at this lesion, which is one of my own pictures, and I apologize, it's okay, but I'm never going to biopsy one of these lesions again. I don't know if anybody wants to guess what that is, but no, okay. But basically, you might confuse something like this for a basal cell carcinoma, but it's a clear cell acanthoma, so it has a distinct pattern. So, this is one way in which we can save patients and the system money because of a new technology. Move forward, please. And one of the things like Toby brought up is that, at AP Derm, we are really kind of community clinicians with an academic type feel and collaboration. And that's what most people in the United States are doing. A lot of the things that are brought about start in the sort of the incubator of the academy, but we are the people who are actually on the ground floor seeing most patients. And something that works in an academic setting might not translate to the vast majority of people who are actually doing dermatology on a day-to-day basis. So this is a unique opportunity for us as AP Derm clinicians to really step out there and translate things both for the people developing new innovations and for the people that might want to use them, and come up with best practices as how you can actually integrate them into your clinic. One more step forward, please. And that's basically what I was summing up. So keep going. So for a few next steps we're going to do over the coming months, one of the things I'm excited about and I've been doing for a few years is this corona psoriasis and the atopic dermatitis registries. I think 2021 should be the year that we reclaim corona as a good thing and say nuts to this virus. I remember about a year ago, I was giving a presentation to y'all saying the coronavirus is coming, and we're talking about this longitudinal observation study. But basically, this is a way we fill out surveys for patients with psoriasis on biologics. And it will be coming for atopic dermatitis because there's going to be an explosion in those patients too with some of the new therapeutics. So I'm hoping somebody will be interested in joining us. A few people will be interested in joining this as investigators. We also want to develop the infrastructure to support some phase 2 and 3 industry-sponsored research. Like I said, resources on Clinician Central to help direct people who want to publish case reports or other worthwhile findings they see. And again, with more of the machine innovations and basically things we can activate broadly across the organization, like total body imaging as a standard of care, And again, these things are constantly changing and they're not all going to be good. So we want to get feedback from what people might be interested in and what types of innovations they might want to try to bring to bear to solve problems that we see through our day-to-day clinic flow. Next slide, please. So this is a quick little slide on this Corona Research Registry again. I want to say that any patient over 18 years with psoriasis on a biologic or systemic who changed in the last year is eligible for this. This is a survey instrument you gather at regular 6-month visits. My MA, Nicole St. George, is going to be the registry coordinator. She inputs all the data for us. There are some minimal requirements for trainers, for training for people who are interested, something called good clinical practice, which is a basis of all research. And then the POSI assessment, which is a little more slightly detailed version of the body surface area and investigator global assessment. So these are pretty quick and easy trainings you can do online if anybody's interested in joining. And similar inclusion criteria are there for the atopic dermatitis registry that we will be starting soon. So please do feel free to email me if you're interested in integrating this to your site. I would say it's not a small fact when it comes to reimbursement. Initial visits are, I believe, per patient, there's a reimbursement of $500, and it's follow-up visits is about $300. So that adds up quick. I have about 40 patients in there now. So if they all come every 6 months, we're not talking about a small amount that to benefit both you and the organization. So next slide, please. And I think I'm going to turn it back over to Toby for a second, unless you want me to keep going.
You can keep going on this slide.
Sure. So again, total body photography with Skin.io is something that Toby and I talked about last year, and we're hoping to kind of roll out a little more broadly. Then, of course, we got hit by that freight train of Corona. So total body photography really is, it's sort of standard of care at the academic centers. And one of the things we wanted to do was bring it to AP Derm in a meaningful and usable way. And so patients with lots of atypical nevi now with this, with Skin.io, that iPad-based application, you can do standardized photography, which is basically using algorithms and machine learning within the cloud to map patients' moles, to map changes to their moles, and to be an augmented decision maker when it comes to decisions to biopsy or to evaluate changes within patients with either just many dysplastic nevi or dysplastic nevus syndrome. The hope being that it can identify things, again, with an augmented intelligence type framework to be able to make your decision making just a little bit easier and helpful. Also, this is relatively easy to acquire. There are standardized practices, and basically you hang up a blue felt background behind your patients and your MA takes standardized images. One of the things I also like with this is your patients own the data, so it's theirs that transfers with them. It's secure and encrypted and HIPAA compliant. So I'm right now have a list of patients. I'm about to get going with this. They have the option right now to potentially submit for reimbursement, but most of the time this is not really a very well covered service by insurance. So a lot of we're suggesting an out-of-pocket outlay for patients that are interested of a modest amount, and then a smaller amount for follow-ups over the every year or two interval to kind of continually map their moles. So I have a lot of interest from the patients that I've approached about this, and I think really it will make us stand out as clinicians who are dedicated to these patients and getting them tools to help monitor themselves and come in when they have changes. This will help them. Again, they can access at any point. So next slide. Excellent.
All right, so I'm gonna kind of zip through these next ones. So centers of excellence next. So there is already a lot of expertise at AP Derm, and I don't have to really go into it, right? So we have nail care, really complex med. So yeah, I'm not going to go into too much, but there's already all interesting folks here. Next slide. So what we're trying to do is actually create a clinical, clinician-driven pilot of centers of excellence to reflect this expertise. So the first one would be a surgical oncology center for excellence, which would be led by the DPI team. So it's going to be specializing in high-risk skin cancer care, working with an interdisciplinary group of other treating folks, like radiation oncologists, general surgeons, plastic surgeons. And really this will be increasing the number of referrals and really getting us known as a really efficient, high quality center in the Rhode Island and potentially Massachusetts area. We're also thinking about bringing back patch testing, which DA used to be known for being a non-academic center of excellence for patch testing. And We have a lot of folks in our group who are contact dermatitis experts, and integrated rash clinic really bringing complex med derm with John's expertise back here. Next slide. And then improving clinical workflows and MIPS. Next slide. Megan already talked about this, and we'll be speaking about this a lot more, but we've created an MA Partner of Choice program. That's a dedicated career path for MAs to advance. There is going to be an amazing, I can't wait for you guys to see it. I've gotten a peek at it, MA training to really improve what they can do. You already heard that we're getting ancillary MAs trained. We're creating a scope of practice for MAs so they know what they can and cannot do at all the different levels. So this is going to be really great, and hopefully will improve their retention and satisfaction here. Next slide. And then MIPS, I already talked about it. Next slide. So if you have any questions, please let me know. Next slide. And there is kind of a complex timeline, but basically throughout the year, you're going to be hearing from myself, from Bernadette, from John, and from various folks who are working on different aspects of this, our quality program. But this is why we're all here, right? You know, we were all nerds, I guess, grew up really loving dermatology, really loving skin, and really wanting to make a difference for our patients. And the fact that we can do that here at AP Derm, I think just makes it all more exciting. All right. Rich, sorry, I know
No, great. All good stuff. Thank you very much. You went through that in a hurry. There is a lot to cover. This was a very dense meeting agenda. So thank you everybody for running through that. Normally, this is when we have a chance to present interesting cases or raise any questions. We are almost out of time. So unless there's a really pressing question, raise your hand, let us know. We'll squeeze it in here. Otherwise, we'll just wrap up with a couple of announcements. So next slide, please. There is continued stress on all organizations, particularly healthcare organizations. You may have read about the 2 small hospital systems that had their IT infrastructure hijacked basically and held for ransom. And if you think about something like that, how that would impact our ability to treat patients and track things, it would be horrible. So Mark has the unenviable job of constantly trying to make sure that our defenses are in place. So he wants to talk a little bit about a new step that we're taking. Mark?
Yeah, thanks, Rich. And yeah, that's really the point behind Okta here. We do a security risk assessment usually every year, and this was one of the areas where we had sort of the highest impact for us to be able to have higher security controls. So if you could set up your Okta account if you haven't done so yet, really this is going to increase security across the board for us. I know there's been a lot of change recently, and that is stressful for everyone, but this is really a great platform for us to be able to extend the security to a lot of our different systems that we use. So I don't get to say that all the time. This is going to be something that is increasing security, but also hopefully making things a little bit easier for you. So Okta has self-service options for password reset and unlock, and you're going to be able to use that password for a lot of our systems. So the same password all the time. When you change it, it changes for everything, and you won't hopefully have as many issues with logging in. So if you have any issues or questions, please reach out to me or send an email to helpdesk@apderm.com. Thank you.
Thanks, Mark. As I can't stress it enough, it's really important. We spent a lot of time at the board meeting talking about this. This has really risen in the risk for all healthcare organizations because the value on the dark web of a health record is so much more valuable than financial information, believe it or not. And there are a lot of evil people out there trying to get it. So thanks everybody for spending your evening with us. Our next meeting is March 11th, second Thursday of the month. And we've got a nice outside speaker. It should be a great meeting. I'm assuming no questions came in while we were talking before. Anything anybody else wanted to add?
I don't see any here. Nope.
With that, look for your Survey Monkey so you get your CME credit. We'll send that out tomorrow morning. And thank you, everybody, and have a great evening. Take care.
Thanks.